I am Dr. Mark Mattar, and I am the program director for the Gastroenterology Fellowship Program, along with the Inflammatory Bowel Disease Center here at MedStar Georgetown University Hospital. So I mainly treat patients with inflammatory bowel disease, which include Crohn's disease and ulcerative colitis. In Crohn's disease and ulcerative colitis, there are a lot of dimensions to that, and some of it relates to the actual disease activity, and some of it relates to different medications that can help them. Our philosophy of care is to really try to look at the whole person and really use a multidisciplinary approach into treating our patients. It really takes a village. What I love about working here and with our patients is that we could really see a turnaround in our patients' symptoms and really kind of give them back their lives. So we have patients with sometimes debilitating blood in the stool or diarrhea, things that kind of keeps them out of work or functioning or school. It's nice to see them get better and get back to normal life. I believe someone should choose MedStar Georgetown University Hospital for their GI care because of its academic advancements. We have trainees from the gastroenterology fellows, the trainees, med students and residents involved in care with our patients, along with research and clinical trials and advanced therapies that can be made available in the future to our patients. So inflammatory bowel disease, or IBD, is an inflammatory process throughout the bowel. There's two main types, Crohn's disease and ulcerative colitis. Crohn's disease can affect anywhere from mouth to anus. Mainly, usually it affects the connection between the small intestine, or the ileum, and the beginning of the colon, or the large intestine. Ulcerative colitis, as the name kind of implies, it's in the colon. So in the large intestine or colon, we see inflammation, meaning redness, angry-looking lining in the colon or the large intestine, which can cause blood in the stool, diarrhea, abdominal pain, and different types of symptoms. So you would know you have inflammatory bowel disease really by sometimes symptoms, so blood in the stool, diarrhea, change of bowel habits that's more chronic, or other types of symptoms. Otherwise, sometimes it's hard to really find out. The gold standard for knowing if we have it or not is by seeing your gastroenterologist, and a lot of times that's where we would perform a colonoscopy to take a look directly. So a good time to see a gastroenterologist would be if you have symptoms like blood in the stool, diarrhea, constipation, things that aren't getting better after 1 or 2 weeks. You definitely want to talk to your primary care doctor for a referral or see a gastroenterologist to make sure there's nothing else that they could offer, or they may need to investigate further. IBD entails ulcerative colitis and Crohn's disease, and there's some other nuances to that. But Crohn's disease can affect, again, anywhere between mouth to anus, but it also can be deeper. It can actually cause more and more damage throughout the wall of the intestines versus ulcerative colitis, which tends to be a little bit more superficial in the wall of the bowel when we see that. So with that, Crohn's disease can have other types of complications related to it if it is undertreated or untreated, which means they could have fistula or tunnels that could tunnel through into other organs, to the skin and other areas, or they could have strictures or narrowing of that area because the muscle layers is affected and causing obstructive symptoms. There are different types of reasons we get Crohn's or colitis. A lot of them are unknown. So sometimes it's genetic. So if you have a family history of Crohn's disease, ulcerative colitis in someone close to you, and you have blood in the stool or diarrhea, the symptoms, you may have a lower threshold of seeing a specialist. Otherwise, diet sometimes can be related to it. So avoiding processed foods, preservatives, things like that, leaning more into what we call a Mediterranean diet or an anti-inflammatory diet, may be related to inflammation, whether in your bowel or even your joints or your heart or anywhere else, really. So trying to keep a healthy, well-balanced diet can potentially help with Crohn's or colitis to some degree. So in IBD, fortunately, we have a lot of treatment options. Some of them are complementary to diet and other factors, but also they include medications such as we think of in ulcerative colitis, sort of an aspirin for the colon, and these would be called the mesalamine type of medications, which are pills they take orally. Otherwise, when it gets more advanced, or if you have Crohn's disease, because it hits a little deeper into the bowel, sometimes your physician may recommend a biologic or another medication that's advanced therapy, which means you may be taking intravenous infusions or even having to take injections under your skin at home. In the world of IBD, we look at different factors in how we look at disease control or what we call remission. So what we look at is beyond clinical symptom control. So one thing we look at is, of course, the blood in the stool, the diarrhea, or the change in bowel habits or abdominal pain has improved, but that's only the tip of the iceberg. We always want objective markers of remission, which would include, sometimes we would run some blood tests every 6 to 12 months for inflammation, even some stool tests that can indirectly see what your bowel looks like in terms of inflammation. Otherwise, we look for endoscopic remission. This would be 6 to 12 months after a large change in the medication regimen to look for what we call endoscopic remission. Those are the traditional views. Otherwise, there's imaging too. Traditionally, we have MRIs, what's called MR enterography or CT enterography. That can look also at the bowel, especially if you have Crohn's disease, where again, it's usually in the small intestine that can be better visualized sometimes with these imaging modalities. There are limitations to some of these modalities that we use to evaluate for disease activity monitoring. So for example, colonoscopy does require preparation, time away from work or school, along with usually sedation and medication required for that. MRI or CT or CAT scans do have some radiation involved and also scheduling that we have to look into. MRI, although there's no radiation associated with that, it is still something we would need to schedule with radiology department and potentially have a wait for that. There are also limitations with MRI or CT where looking at the colon, the large intestine, isn't as good as colonoscopy or other modalities. And the other modalities that would potentially help with this, or is one that we're currently doing at MedStar Georgetown, is at bedside intestinal ultrasound. So what that entails is actually taking a probe, just like you would for some folks at the OB-GYN office, but it'll be in the abdomen with a probe, ultrasound probe, and in real time with no radiation during the clinic visit, actually be able to evaluate the colon and the end of the small intestine, the terminal ileum, for ulcerative colitis or Crohn's. With that, this also has its limitations. So although it's in real time, no radiation involved, and we could get answers right away, it does have some limitations of, especially if you only have the rectum involved, that's deep in the pelvis, that is harder to visualize with a bedside ultrasound. So you may need a colonoscopy or flexible sigmoidoscopy to look at that a little bit closer. Otherwise, another limitation would be if your disease is mainly high up in the middle of the small intestine, then we wouldn't be able to see too much with a bedside ultrasound. Yeah, another advantage of this is that there's no sedation involved. This is, again, real time in the clinic, just a part of your office visit, so no need to need a ride or feel groggy or anything like that after a sedative procedure. There are some complementary things that can help with Crohn's and colitis. And I say complementary to mean not alternative. So you usually still do need medication, but still there are some things that can help. So exercise, even keeping a healthy lifestyle in general can be beneficial to keeping your Crohn's and ulcerative colitis at bay, as long as, again, you take your medications as prescribed. Otherwise, diets can also help. If you lean more into a Mediterranean diet, that has been shown to also be beneficial, especially in Crohn's disease or ulcerative colitis when it's mild, along, again, complementary to the medication, which can help decrease the number of flares or the actual inflammation in your gut. If standard medication and lifestyle modifications don't work, unfortunately, sometimes patients do need surgery. So that's where we partner closely with our colorectal surgeon colleagues for different types of surgeries when needed. So this may involve taking out a small area of a narrowed or a strictured Crohn's segment, or even getting into the colon resection in patients with ulcerative colitis. So chronic ulcerative colitis, when you've had it for over 8 years, can actually put you at increased risk for colon cancer or precancerous lesions in the colon. So that's where we do implement colonoscopy every 2 to 3 years, or even sooner sometimes, once you had chronic colitis for that long, to help prevent colon cancer. Otherwise, always remember, if you're over 45 with or without inflammatory bowel disease, make sure you do get screened for colon cancer, even for generally healthy individuals. If your screening colonoscopy is normal and you do not have inflammatory bowel disease, and you do not have any other risk factors like a family history of someone with colon cancer or large colon polyps, then you would go on to every 10-year colonoscopy scheduling program. We're excited about the future of IBD care and in gastroenterology in general. As I mentioned, ultrasound at the bedside is going to become more and more available through our units and office visit. I think of it as an extension of the physical exam. So hopefully we'll have more and more training programs so we could have our colleagues also join us in training and optimizing how we do this. Other advancements in GI in general is we are using AI, artificial intelligence, in ways to help detect abnormalities. This would include when we do colonoscopy, if it's not that obvious that there's inflammation, AI programs may help us identify areas of inflammation. Even more relevant, probably for screening colonoscopies, help us identify polyps where we may otherwise not look. So I think artificial intelligence also is going to help us in our world in GI. No matter what GI problems you have, MedStar Georgetown is here to help support you, and it does take a village sometimes. So we do have our nurse practitioners, physician assistants, medical team, academic team in terms of residents and fellows working with us to really create that multidisciplinary sort of approach, and of course with colorectal surgeons as we need, and also sometimes dietitians or mental health support throughout your journey.